right, I've got a couple cases. I know we're running short on time, so I'm going to be talking quick. You'll probably be. We'll do one case. I'll still be talking quite quick. So I know I'm staying between you guys and lunch and the beach. So disclosures, I wish. For case one, this is born to be leaky, an unlikely culprit of severe TR. So we got a 73-year-old guy who came in with a known history of congenital heart disease, chronic shortness of breath, fatigue, and a 30-pound weight loss. He endorsed fatigue for several months. He had worsening lower extremity edema and abdominal distension. And he was recently admitted to the outside hospital where he was referred from with right-sided volume overload, tachybrady. They initially were going to place a pacemaker in him, and then they found out he had chronic severe TR and RV failure, and so they referred him to us for TTVI evaluation. So busy slide. I think the most important thing here is that these patients come in with multiple comorbidities. For him, the most notable thing is that he had severe chronic TR, moderate severe AS, congestive hepatopathy, and his congenital heart disease is characterized by having a coarct repair at age 9, and then an ASD and muscular VSD repair when he was 12 years old in the 1960s. He had a residual muscular VSD despite this surgery. So when he came in to see us after being referred, he was put on a little bit diuretic from the outside hospital, comes in, and he's remarkably cachectic, BMI of 17. He's got evidence of right-sided volume overload, JVD to the jaw in the upright seated position with significant V waves. He's in AFib. He's got a murmur consistent with TR as well. And otherwise, his lower extremity edema has considerably improved. So if you look through his chart history when he was coming in to see us, we kept seeing notes of, severe pulmonary hypertension that was based on echo. So I'll just pull up the echo here and kind of go through it quickly in the interest of time. But you can see right away he's got severe RV failure. He's got torrential TR that's kind of septally directed here in this, and we'll keep moving forward. Again, you can see how the septal leaflet it's shortened, it's thickened, it's retracted, and you have this, significant TR. Forward. Again, RV is quite dilated. You can see just how big that RA is. You have a frank coaptation gap there. And then nicely, same thing. You're seeing that septal leaflet just completely kind of affixed down. And you're starting to get the sense of, hey, maybe there's that VSD. Let's keep moving forward. We've got color compare on here. Gives you a sense of that TR again. And here I kind of did a screen grab of one of these images. You're starting to get a sense of where that TR is actually originating from. Same thing. Again, I think a nice shot that shows the origination of that jet, and you can see how when they sampled across this to get an idea of the TR, they were sampling right across where that VSD was, where the jet was coming, suggesting that it was a contaminated jet, and that's where we were getting a report of RV systolics in the 80s. Again, here you can start seeing that VSD a little bit better. And so next steps, again, we're just going to move forward. Here's TE. You can see essentially there's a huge coaptation gap. The septal leaflet is completely kind of affixed down towards the septum. You can see all the color in there. And we have CT reconstruction. You can see that the VSD here as well, and just how enormous that RA is. So he went for a right heart cath, and again, the pulmonary pressures were actually completely normal, which was a nice kind of proof of concept that this TR jet was being contaminated by the VSD signal, which was making everyone think he had severe pulmonary hypertension, which is important when you're considering patients for transcatheter therapies here. He had a small step up in his SVO2 from 62 to 66% when he went from the RA to the RV, but otherwise the QPQS was not significant. So we added essentially this to the note, normal pressures on cath. And so kind of putting it all together, maybe for the panel, what next steps would be. Otherwise, I can move forward and tell you guys what we did.
Yeah, let's just move forward.
All right, so what we did is nothing. Unfortunately for this guy, because of the thickened leaflets, retracted and fixed septal leaflet, the very prominent subvalvular apparatus, that large coaptation gap, not a candidate for TriClip, and TTVR, because, with Evoke, you really rely on that subvalvular anchoring mechanism. There's a lot of concern that given how thickened and distorted it was in the presence of a VSD, that we'd further distort the anatomy and we wouldn't get a good seal. Moreover, the guy had resolution of his bilateral lower extremity edema with optimal medical therapy, which, again, we had a debate earlier today as to kind of next steps. And because of this, we're now evaluating him for trach valve or heterotopic cable valve implantation.
Was there any role for VSD closure?
No, it seemed to be a very restrictive VSD in that the effect over time was that the turbulence was leading to that septal leaflet just, being opposed to the septum and leading to wide open TR. So I had a number of teaching points that we're not going to get into. But again, here's just, these very nice valvular anatomy shots, and basically to illustrate that the subvalvular anatomy is incredibly complex. You can have a number of different leaflets, a number of different PAP muscles. You can have direct chordae insertion directly into the actual septum itself and onto a PAP, and this dense web-like cords can really challenge how we do this. I don't need to convince you all of the role of multimodal imaging. And so in terms of clinical takeaways, is just a very interesting case of how congenital heart disease can cause anatomic distortions of our tricuspid valve, the role of the restrictive VSD contaminating that TR signal, how we need to look at our subvalvular anatomy, and that CAVI might be a therapeutic option in patients who kind of screen out for TriClip and for TTVR. So with that, thank you very much.